Hello, everybody, and welcome to the Kidney Foundation of Ohio, the cost of transplantation, looking at the transplant financial overview. Just a few housekeeping things. Kidney Foundation of Ohio, we are a broad-based direct assistance program for patients with kidney disease, and we provide educational programming for the general public, renal professionals, patients, and their families. Below is a map of the 32 county area that we service in northern and eastern Ohio, with 2 affiliate chapters in Lake and Summit County. We are currently one of the only health and human service agencies in Northeast Ohio, which continues to provide direct dollars to patients to assist through the devastation of kidney disease. The foundation remains an Ohio-based organization, and all funds in Ohio stay in Ohio to help our patients. So today's webinar will last about an hour. Questions can be submitted through the question and answer feature on your screen during or directly following today's presentation. If time permits, we will ask those questions at the conclusion of today's session. There is a recording of this webinar, which will be sent following the session. Continuing education is not available for watching the video. For future sessions, visit Kidney Foundation, the www.kfohio.org. By signing up for this webinar, your email will be added to the KFO email list, and you'll receive information. At the conclusion of today's webinar, there will be an evaluation. If you are seeking CEUs, you are required to complete that evaluation. And currently, today's presentation has been approved by the National Association of Social Workers for 1 continuing education hours. At this time, I'm going to turn it over to Larice with the University Hospital to go ahead and introduce our speakers.
Thank you, and good morning. My name is Larice Stackduke. I'm the Outreach Coordinator at University Hospital Transplant Institute, and it's my pleasure to introduce our speakers this morning. Chris.
Hey, Larice, you muted yourself on X.
Yeah, so the host would like to.
There we go. Okay, thank you. Good morning. My name is Larice Stackduke, and I'm the Outreach Coordinator at University Hospital Transplant Institute. And it is my pleasure to introduce our speakers this morning. Chris Shay-Downer, who's the Administrative Director at University Hospital CMC Transplant Institute, and she earned her BSN from University of Pittsburgh and her MBA from Baldwin Wallace. And Lewis Goldsmith, who is the Operations Strategist at University Hospital CMC Transplant Institute. He earned his Bachelor of Science in Health Service Management from East Carolina University and his MBA and Master of Health Administration from Pfeiffer University.
Good morning, everyone. So before we get started, I want to check the participants to see if we got a couple people online. If you can check with me too, Chris, I'm making sure that Cynthia and Tom and then the social workers are on.
If you click, it says participants in the top bar. Do you see?
And while you guys are checking that out, everyone, I just, before Lewis kind of digs in and gets started, it's great to be back, with this group. I know that we have at UH, we have a great partnership with KFO, and we totally appreciate them and value that, within our transplant and renal failure community. I think we work hard, to try to work with them to offer education on topics that are important to all of you, right? And so the financial consideration topic is one that seemed to kind of bubble up to the top, so that we can, you know, help our patients to better prepare and then also to navigate, right, their transplant journey, because it's not easy. And so it's so important, you know, to help them prepare prior to transplant, because there are just, you know, so many avenues, right, and alleyways and things that can happen afterwards. And it's really helpful to be as prepared as possible, and to help them, you know, prepare for that journey. So we plan today, Lewis is going to dig in. You know, our purpose is to really present a bit of a higher level picture of this topic, and then open up the floor, you know, for questions and for conversation, and, you know, maybe to help, you know, you all, you know, as you're interacting with the patients, because you see them so often, right, prior to transplant, you know, kind of help you to address questions that they have. Or, right, if you don't know the answers, I mean, we don't know the answers to everything, at least help to get them, right, to the right people and help to direct them, you know, appropriately, so that we can help them to be successful in their journey and promote the best outcomes possible. So thank you, KFO. Thank you all for joining. Thanks for having us back. And Lewis, when you're ready, let's dig in.
Okay. First slide. Okay, well, first of all, as Chris just noted, I want to thank everyone for joining us, and thank you for having Chris and I come and speak. It's an honor and a privilege to come and talk about what we do and what we believe in each and every day. So I do want to address that there's no financial conflicts to disclose. Next slide. All right, so we have a couple of objectives. So the first thing we're going to talk about are transplant costs, the financial preparation of the transplant, talk a little bit about the medical insurance coverages, a little bit about the bundle payment model, and what we consider centers of excellence. And the last thing we'll talk about is a little bit of guidance for transplant safety. So in 2024, the average cost of a kidney in the United States was around $442,000. Some of those items that included in that price are your pre and your post-transplant care, your insurance coverage, the actual transplant center of where the transplant will be performed, and the location, like the actual state. So the most expensive line of the transplant is the admission, which accounts for 34% of the total costs. So the immunosuppressants, which are the drugs that's given for the transplant, and other related medication account for 7% of those total costs. So this graph right here and everything, I just want everybody to know these are just estimates as well. It's not to be exact. So in the United States, as I said previously, it costs over $400,000. The waiting period is averaged between 3 to 5 years. Over in Canada, it costs $145,000. The waiting period, 2.5, 3 years. In the United Kingdom, it's almost $70,000, and the waiting period is 2 to 3 years. And in Australia, it's almost $100,000, and the waiting period is a little bit over 2 years. So you can see the difference in the variation of the cost. The waiting period is pretty much the same, but the cost, you can see a big difference. Next slide, please. And these are just some variation of different costs that we have. And again, it's all estimation costs. So the pre-transplant medical care needs, that'll run you about $32,000. The organ procurement a little bit over $100,000. The hospital admission for the transplant over $152,000. The physician costs for the transplant, $26,000. The post-transplant medical care needs is over $85,000. And again, the immunosuppressants, the medication is over $31,000. So this next slide, we're going to be talking a little bit about how you can prepare for the transplant. So the number one thing that we suggest that you do is you understand your insurance coverage. So that's including with your deductible, your copayment, and your out-of-pocket maximums, and ensure that you have prescription coverage for your transplant medications as well, because your medications are going to be very vital for a successful transplant. The next item is a long-term cost. So in addition to the cost of the transplant itself, you want to consider the cost of medications again, follow-up visits, and periodic testing for the rest of your life. They do offer some financial assistance. So I'm not sure, but it is possible that we have our financial coordinators on the line. So Cynthia and Tom, and then our social workers on the line, Tiana, Fiona, and Annie, they could possibly be on the line. So we'll ask if they're on the line later on throughout the presentation. So additional items to consider is your child care, lost wages, lodging, meals, insurance premiums, and your Social Security disability as well. And you can also connect with the Transplant House. Transplant House is a organization that helps as well, and it's actually located right here in Cleveland. So as far as fundraising, you have a couple items here for fundraising. So you can submit a campaign request with Help Hope Live. Also, everyone is aware of a GoFundMe as well with your family and friends. The American Transplant Foundation, our very own Kidney Foundation of Ohio, and also the National Kidney Foundation. So now we're going to get into what I like to call the nitty gritty of the different type of insurances. So you have your Medicare Part A, that's going to cover your kidney registry fee, and also you have to be in a Medicare certified hospital to get this transplant performed. It's going to cover the blood and any other laboratory and tests to evaluate your medication. I mean, your medical condition, I'm sorry. Okay, a little continuation of the Medicare Part A is the full cost of care for your kidney donor. You and your donor won't have to pay a deductible, co-insurance, or any other costs for the donor's hospital stay. And then any other additional inpatient hospital care for your donor in case of any problems from the surgery. So that wraps up the Medicare Part A part. Moving over into the Part B, that covers the outpatient visits and the testing procedures. So, and one quick thing to note, that if a patient has Medicare at the time of the transplant, Part B will cover your immunosuppression drugs at 80%. That's just a little fun fact. Next slide, please. So now you have your Medicare Part C, and this is just a supplement insurance plan that you can have, also known as the Medicare Advantage plan. The Medicare Part D, it covers some of your immunosuppressant medication, and then Medicaid. The trick about Medicaid is it will only cover your transplant in the state where you receive Medicaid. So if you were supposed to go to another state to have that transplant performed, the Medicaid portion wouldn't cover it. And private insurance. So you have many private insurances that offer coverage for kidney transplants. Private plans usually offer some coverage for the immunosuppressant medication, but the number one rule that you should always remember is to always contact your medical insurance plan providers for the very specific details. Okay, now we're going to jump in a little bit to the bundle payment. And Chris, if you want to jump in at any time, feel free to, okay? So the bundle payment model is a healthcare payment structure that provides one single payment that covers all the services in that particular episode of care. So for instance, if you have, just to give you an example, if you had tests done, labs done, the actual stay, it bundles it for that one particular episode of care. And the reason why they do bundle payment models, it improves the quality of coordination and the care, and the actual providers are incentivized to work together to improve the coordination of care. And it also reduces any unnecessary or duplicate tests and treatments. And again, going back to the providers, they're rewarded to reduce unnecessary or duplicate tests and treatments. And healthcare facilities and providers share in the financial risk and outcomes associated with the episode of care. Okay, now we're going to jump into what the Centers of Excellence. Oh, another thing that I wanted to say as well is with the bundle payments, UH has a department in our revenue services that handles strictly bundle payments. That's all they work on. They are the financial experts of the bundle payment, and I rely heavily on them, to be honest. And the Centers of Excellence, we have Melissa Lewis. Melissa Lewis, she handles our Centers for Excellence. So she's very knowledgeable about the COEs. And just to break down what a COE is, it's a specialized program within a healthcare institution that provides high quality care in a particular medical area. And the way how it's structured, it depends on the particular payer that you have. So Aetna will be different than Blue Cross Blue Shield and so forth. And they like to focus on a specific condition or medical area, such as transplants. It could be heart, it could be lung, it could be whatever type of organ. And the care, it provides comprehensive interdisciplinary care that combines patient care with research and education. The next portion is the outcomes. The outcomes for the dedication to improving clinical outcomes and patient experience. And we use this registry that's called SRTR. It stands for the Scientific Registry of Transplant Recipients. That's the data where it is evaluated. The resources, we have a high concentration of expertise in those related resources. The best practices are based off of literature-based care and collaborative work of all disciplines. And the last piece of it is the key elements of a true COE. It includes consistently delivering excellent outcomes, outstanding safety ratings, and a patient-first approach. Okay, and this is our last slide, what we like to discuss. It's the clinical guidance for the transplant safety. So the donor screening and testing. So we want to make sure that we do the testing to eliminate any type of risk behaviors that may expose the donor to certain diseases, the donor's past medical history, and any type of relevant travel history, which can be important to the exposure of certain pathogens. The laboratory testing is another piece for infectious disease. So the Organ Procurement Transportation Network, which is short for OPTN, provides the organ procurement operations and hospitals that receive living donor owners' organs to perform the following tests for donors. And I'm not going to read all the different tests, but you can see it's a very extensive testing where they test different diseases and things of that nature. So the last key points I would like to make is that every organ donor can save as many as 8 lives and enhance 75 more. So let me say that one more time so that can sink in as far as the impact of donation. Every organ donor can save as many as 8 lives and enhance 75 more. That's amazing. While rare, an infection can be transmitted through an organ transplant form from donor to recipient, but this occurs in less than 1% of all transplants. So that number is very low. So I wouldn't really, worry about any type of infections. So several safety measures are in place to lessen the risk of disease transmission to ensure every usable organ is used safely. I got one last slide. So, and these are just some recommendations to always contact your insurance company to verify if they offer any travel or lodging benefits. Make sure you always prepare an emergency fund for any unexpected financial items. Contact your case manager to see what medications are covered. And then you will also like to connect with Trio and Motel. So TRIO is the Transplant Recipients International Organization, and then Minority Organ Tissue Transplant Education Program. And these organizations are here to provide community support.
So Louis, there's a couple questions that came up. I should turn that down a little bit. So you discussed the cost of transplant is over $400,000. Do you know what typically the cost is to the patient?
And again, it would depend on your particular insurance provider. Like I don't want to state any type of numbers. The best better rule of thumb is to contact your specific insurance so they can give you better details.
Yeah. And for those on the call, obviously Medicare covers at 80%. So if patients don't have like a Medicare supplement plan or secondary insurance or Medicaid, then they would be responsible for 80%. All right, the next question, it says, do you know why the cost is almost 4 times that of a transplant in the US than it is in other countries?
That is a great question. And the reason I would say is based off location. You know, different countries prioritize care a little different. So I don't have a standalone answer for that, but that's what I would say based off the location.
Okay.
Yeah, and I think
the next question is, what can dialysis healthcare professionals do to help make sure patients get a transplant or get on the transplant list?
Hey, Jen, sorry.
Maybe something Chris might be covering here shortly.
You want to take that one, Chris?
Yeah, this is, let me step back just a minute, you know, just related to the cost of transplant in the US. I think that Louis is right. I think there are multiple factors that kind of feed into that, to be honest, you know, within different countries, right? Like just as baseline, there are very different healthcare structures in different countries, you know, and so not every country has insurance, you know, like we do, and a healthcare structure like we do. So for example, right, if we go to Canada, they have socialized medicine. So for many, you know, conditions, when someone needs care, they all have government coverage. And my understanding is they, you know, when they need care, they wait in line for their care, right? Because every citizen in that country is treated exactly the same, you know, as far as their urgency goes, right, for healthcare. If we think about countries, so we have a transplant nephrologist here that's from Thailand. Some of you may know her, Dr. Jitterat. Dr. Puck, many of the patients know her by. And so she and I were just talking about, you know, healthcare in Thailand last week. And so they kind of have a system, you know, and whether we agree with it or not, right, it's what exists, but they kind of have a system where, you know, they have hospitals in their country that, you know, their citizens will go to if they can afford to pay out of pocket. Like there is no such thing as health insurance in Thailand. So they either go to hospitals where they can pay for their health care, or they go to hospitals where they can't pay for their health care. And so they get care, right, at both places, but that may look a little different. And the care might be a little bit different. And who they hire as their providers might look a little different. So it's interesting, you know, as we expand outside the United States, you know, to kind of become more aware of what the different types of structures are across the world. It's extremely interesting to be exposed to that. So I think the healthcare structure is one piece. You know, I think as we look at in different areas, you know, across countries and across the world, you know, transplant is not everywhere, you know, right? And not in every hospital. So even just in the US, only about 4% of hospitals in the entire United States have any type of transplant activity. So, you know, when you think of it, right, that's a really small percentage and a pretty kind of expertise, you know, area of healthcare. And so, um, you know, based on that, you know, even in the United States, you know, your out-of-pocket costs certainly are related to what your coverage is, your coverage plan, right? And whether it's government or private. But it could also be related to, you know, where you go for transplant. So, you know, we are here for the patients, of course, but we know that healthcare is a business too. So when you go to an area you know, for example, like California, there are multiple transplant centers in California. So cost of living and things are higher in California, but there's a lot of competition between transplant centers for business, right? For patients to kind of come to them. So their payment structure even may look a little bit different than ours in Ohio. So I think, you know, there's a lot of variables in that piece. I think the number of transplant centers and how they, you know, what their kind of focus population is, can make a difference. And I think too, you know, we have in the United States a pretty structured process through UNOS for promoting a fair and equitable distribution of donor organs, right? And donor tissue. And so that does not exist everywhere too. Like that system I don't want to say it's not fair and equitable, but the process that they use to promote that looks different, right? From country to country. So I think there's a lot of the cost, right, is related to a lot of variables, you know, just within the different healthcare structures and, you know, particularly in transplant. So I hope that that is kind of helpful and gives you a little more, you know, just information to consider about that.
Thank you, Chris. What
No, that's
about what can dialysis professionals do to make patients get a transplant? And I think a key thing there is education.
Yeah, education is huge. You know, I think you know, if we think about, right, you all work in a dialysis center every day, you live that life, right? There's a lot that you know that's very natural to you. I think it's the same in transplant, right? Even though it's a very small percentage of our healthcare structure, right? We live it every day, you know, and so it's a normal verbiage, it's normal vocabulary, you know what I mean? It's just kind of part of our life, but it is not for our patients. It's totally new. And it's totally foreign, and there's a lot of uncertainty, right? So any patient that's being referred for transplant, there's a lot of uncertainty there. And even if they get through the process and they get listed for transplant, right, they're not guaranteed a transplant because simply, I mean, the most simplest reason, right, is because we have and this is not a new problem, it's been with us for many, many years, but we have more patients that need transplant than organs that are available out there, right, to transplant everybody. So, and there's lots of research and things going on to close that gap. But, you know, none of them tend to be things that are going to fix us tomorrow, you know, so you know, hopefully things will continue to improve over time. But I think if we think about you know, the interactions that we have with the patients kind of one-on-one, when you guys are seeing them in the, you know, when they're on dialysis, when we see them in clinic or for appointments, you know, those kinds of things. I think you know, we can never talk about the process, you know, where they are with how they're feeling about transplant and their preparation for transplant. We can kind of never talk about it enough, right? Because, you know, when they come to see us for transplant, we do head to toe, inside and out evaluation, and we say, okay, we're good. We believe that you are a good candidate for a kidney transplant, and we're going to place you on the list for that. But you know, we saw the wait times potentially for kidney transplant, and a lot can change, right, in that time frame. So, you know, when the patient's evaluated, they may have a great, strong support system, but that could change, right, before they receive their transplant, and that could set them up for being not as successful afterwards, right? Financial situations can change, relationships can change. I think there's a lot of those social, you know, type circumstances that can change in a patient's life that can increase how challenging it's going to be after transplant, to be successful and to have, you know, a, a beneficial journey. Other than kind of those social circumstances, I think, like Jen said, right, the education piece is important. I Every time we interact with a patient, right, all of us, there's typically some sort of education, right, that we're providing. And so we talk to, the patients. We have, from a regulatory standpoint, right, we have points in the transplant process where we are required to provide education and then to have the patient sign a consent that says, I have been educated, I've had an opportunity to ask questions, and I'm agreeable to move to the next step. So for example, when they come to us for their evaluation, before we can do any testing or any type of billable appointments, we do an education class that they come to with their support person or persons, right? Whatever that looks like. And so, we kind of walk through that process, both pre-transplant and post-transplant. Now, a lot of information, right? It's crazy to think that they're going to remember all of those details, but they have a consent that they sign afterwards that mimics that education. And so that consent they get a copy of it, of course, and it's a great resource, to kind of review some of the details around the process. And so I think that, if you referred them back, to that consent, that could be a great resource. We also have educational videos that we could send the patients or that we could provide to the dialysis centers so that you could even have available there, right? If you've got patients that's going to be on, their dialysis, it's going to take 3 hours for their treatment, they could certainly review. And so, I don't know, in my opinion, right, we can never review enough because there's just so much involved and there's so many variables. Another point where we do education and consent is at the time for listing, right? So when the patient's going to be listed for transplant, the physician sits down with them, with the coordinator, and they sign a consent for listing. And it talks about, those, what's the word I want? Not criteria, but just the dynamic, right, around listing. We talk about timeframes. We talk about what does listing look like to them specifically in their individualized situation, right? Because no two patients are the same. We talk about what is there, do they have any, we actually talked about this prior, but, are there any living donor opportunities for them? We talk about what would it look like to consider. Lewis talked about, right, the serologies and, a lot of the lab work that we do to look for exposure or existence of various infections and things. So we talk to the patients about, what's the risk in considering a donor organ that the donor was positive for hepatitis C, right? Because it was I'm kind of old school, right? In the olden days, it was taboo, to transplant a hepatitis C positive donor into a hepatitis C negative recipient. But it's very routine these days because, treatment has come so far. So we have conversations with them if it's of interest of them learning about it, that it is possible. And, if they're interested, we can send that for them. And then at the time we call them in for transplant, we review that information with them again, before they would agree to come in and get transplanted. But, we tell them in that situation, we say, you are going to convert, you are going to become Hep C positive, but we have lots of medications and we can eliminate the virus, after a period of months of treatment. So, it's kind of talking to them and weighing the risk and the benefit, of what circumstances, are most applicable to their medical condition. So I think helping them, to keep their kind of, their psychosocial, their support system, as stable as possible, helping them to stay as strong and healthy as possible, right? Encouraging them to ambulate and to stay, as strong as they can. The healthier they are prior, the quicker their recovery is going to be afterwards, right? Because they have that resilience, to recover a little bit quicker. If insurance changes, that's a huge thing for us to be communicated to about. And then we pull Cynthia and Tom into that picture, and talk with the patient about, okay, your insurance changed. How does that change this picture, for transplant? How does it change your coverage? How does it change your out of pocket? How does it change your, co-pays, all of those kinds of things. So, um, I think those are some of the main topics, kind of main subjects that, just having kind of on, not every single visit, of course, but, periodically checking in with the patient, to say, to just say, okay, how, right, are you, do you have someone that could potentially, we want someone to be, if they can't stay with the patient, they at least have to have someone available to them, in the best case scenario, 24/7 for the first couple of weeks after transplant for kidney. For other organ groups, it's much longer, but for kidney, without much complication, that can get us through, right? But I think what we want to do is prepare, you hope for the best, prepare for the worst, right? So that we have kind of backup plans. So, having maybe not one support person, but if there are various people that can kind of pitch in, to help someone after transplant if needed, those things are helpful. And sometimes we have patients, they, reach out to, their church members, they reach out to their community centers, to try to build that, kind of support system. And then financially, once they have some conversations about, their insurance coverage and what that looks like to them personally, then they can think about, okay, this is something, as long as nothing changes, right? This is something that I'm going to be able to shoulder, right? And I'm going to be okay financially, through this. But there are sometimes things change, and sometimes, right, we have patients that are not in that place where they feel like they're good, right? So those are the circumstances where, reaching out to, Live, Love, Hope, are kind of a fundraising organization, right? Well, where they will do most of the work for that patient and their family, and they will also help to manage the money, right? The fundraising money, so that it doesn't affect the patient from a tax perspective. So lots of resources out there for patients. And none of us have a perfect situation, but I think, helping us to help them, have support and resources socially, financially, and also just their own kind of, mental preparedness, for things, I think, helps to set them up for the most success. Helpful, I hope.
Yeah, thank you. What we're going to do is we're going to go ahead with the rest of the presentation. And then if we have time at the end, there's a few more questions. If not, we will send the questions or the answers to the question in the recap when we send out the recording. So I'll let, I think it's back to Chris to finish the presentation.
Yeah, do we have any more slides there, Lewis? No? Okay.
What was that? I'm sorry.
No, that's okay. Do you want to go back maybe to the COE slide? And I think, oh, there it is. Yeah. No, this is great. And I think this is like, I think neat information, for us to be aware of. And so just to kind of, add a little bit to what Lewis shared, on an annual schedule, as a transplant center, we are asked for RFIs, right? Request for information from many payers, main payers. And so we provide them information about our transplant center through UNOS, which is our governing body, right, in transplant. And then there are also sometimes some individual requests for information that come directly from the payer, right? Just to kind of drill down, the payers are looking at us as a transplant center on an annual basis, right? To see if we are a center that they feel that not feel, but based on fact, right, that they would like to send their patients to for care, right? And so do we provide what they consider excellent care for their patients? And so, these facts here that Lewis put on this slide are right characteristics of what payers typically consider a center of excellence. They're not called center of excellence for every payer. Like Aetna may have a different name than, the Blues do or something like that, but it's the same theory, right? They want to be sure that, we have great outcomes, that we have the quantity of transplants that they're looking for to show our experience, and that we have an acceptable cost for transplant. So what is our cost to transplant their patients? And so those are from a high level, right? Those are kind of the three categories that the payers are looking at to decide if they want to send their patients to us. And so on an annual basis, we provide that information, and our status can change actually from year to year. Their criteria can change from year to year. So, just I thought some neat information to just kind of know, about what happens kind of behind the scenes. And sometimes why patients may get directed, to one center over another. I think that we're very lucky in our area, in the Cleveland, greater Cleveland area, Northeast Ohio, because we do have, more than one transplant center. And we're also extremely lucky that we have so many community resources for us as professionals, as well as our patients. So yeah, I think just, reaching out, asking those questions. I have a patient that has this situation. What can we do for them? We're happy to kind of partner about those kinds of things to just, help our patients to have the most successful journey possible. What other questions do we have, Jen?
Oh, sure. So one of the questions I had was asking, there's a couple questions on here. One is there a limit to how many transplants an insurance company will cover over the lifetime of a patient? And then there's also another similar question that asks, does Medicare still cover expenses for a patient who rejected a kidney and are getting a second transplant?
I think it depends on the reason, right? And so I think if we look historically in transplantation, I can give you an example. So I've been a transplant nurse for, we're not talking age, right? Let's talk experience. But I've been a transplant nurse this year for 35 years. And so many, many years ago, when I was a staff nurse on an abdominal transplant floor in Pittsburgh at UPMC, I remember sending a patient to the OR for their 6th liver transplant. And so we think, holy crap, like 6? And that's unheard of these days, right? But back then, some of the same theories applied, right? So he needed a 6th transplant because of his recurrent underlying disease of primary sclerosing cholangitis and the risk of cancer that comes along with that, right? Back then, there were a lot less transplant centers in the country. So we didn't have to, when we talk about that, that equitable, right, sharing of organ donors, there weren't as many centers that needed to share that had, and that had patients that needed to be transplanted. It's maybe a logistical thing, but that's our reality these days, right? So there's about 260-ish kidney transplant programs in the United States now. And so, sharing is important, right? And how do we rate the urgency of the patient so that we're placing those organs in the right place? I think that the decision to retransplant a lot of times starts with the transplant team, right? Because we are caring for them and we're looking at why their kidney may be failing, right? So are they failing because they had delayed graft function after transplant and, maybe we don't know why, right? Or maybe it was something related, to the donor organ that we, this very rarely happens, but, that maybe we were unaware of at the time of transplant, right? Those are a couple situations. It's a totally different picture when we have a patient who is, not taking their medicine, or when we have a patient that has developed kind of a pattern of non-compliance with their care. With that said, though, I think that we always have opportunity to dig into why that is happening. So I think it's very easy, for us to say, oh, that patient's non-compliant. They're telling us they're taking their immunosuppression, but when we do their labs, their prograft level is 0. So we know they're not taking their meds, right? But I think there's lots of opportunity for us to dig in and figure out why, right? We have patients out there that are embarrassed, afraid to call us and tell us, and they could be 5 years out from transplant, but we have patients out there that are trying to decide this month whether they're going to pay their light bill or they're going to buy their immunosuppression. Right. And that's a pretty lousy situation, for them to have to be in. And that's a, a horrible decision to have to make. And the dialysis team may not see the patient, right, in that circumstance, because, hopefully the kidney is functioning well enough, right, that they don't, have to come and see you guys often. But I think, for retransplantation, it starts with the transplant team and the core reason why the kidney has failed. And then we kind of go from there. Getting a kidney transplant isn't easy on the body either, right? And so, sometimes the patients take a toll medically, from the care and the medication and those kinds of things, especially if, their journey, has some bumps in it. So, I think from a transplant team, we are re-looking at them, right, from a head to toe, inside and out, to see if we believe that a retransplant would bring them benefit, right? It's that whole benefit risk discussion. And then, we're kind of, so I think it kind of starts there, with what we're thinking medically, and then we head to the insurance company. So I think that, I don't know, and I don't know if Cynthia and Tom have some insight into this. I'm not aware if different payers have like strict cutoffs, right? Like you've had 2 kidney transplants and we're done. I'm not sure that is the case out there, but because I think there's a lot of variables involved. But we kind of try to, assess that individually and then have conversations with insurance companies. I've been involved in the past too of having, peer-to-peer with physicians, when there are questions, from the payers about, okay, what's happening here? Is this really going to help? We're not sure, right, from a payer perspective that we want to pay for this. And we, want to talk about what those circumstances are. So I guess I don't really have a firm answer, right? Because not sure that there is one. But that's kind of, I think, how we approach, retransplantation.
So I was gonna
I was gonna
ask
ask
if
if
Tom and Cynthia was on the line to add anything
maybe not.
Okay.
So I wanted to mention there was the question about Medicare. So I know if a patient, once they hit that 36-month coordination period where they've had their transplant, they're 3 years post-transplant, their Medicaid may end or Medicare may end. I know that if a patient's kidney does fail, that they can go back on Medicare. So they are eligible when they're back in end stage, which, then they can obviously go through the process of workup for transplantation as well. So that is something that with Medicare piece, I just don't know, like you said, the exact logistics, if there's any barriers or, if any of the insurance companies will say, oh, you're one and done and that's it. You only get one transplant. I'm not aware of that, but I know with Medicare that if a patient does fail, their kidney fails, they are eligible to go back on Medicare.
Good point.
Yeah, great point, Jen. Yeah.
All right. I can't hear her.
I see a
Go
question,
back
I think, from, oh, I'm sorry. Yeah, go ahead.
What was that? I'm sorry.
No, I saw a comment here, I think, from Lee.
Yes.
Right. Many patients who use the American Kidney Fund to pay their insurance premiums, including Medicare and commercial, they are no longer my patient, right? So I can't assist with submitting those requests through the end of their policy period for that year. That would be allowable. Does the transplant financial person assist, or the transplant coordinator or social worker? That's a great question. And so I think that on the transplant team, right, there's a variety of us that can help, to facilitate that process. And so I think, though, primarily it's the transplant coordinator, because every patient is assigned one. Transplant coordinator or one of our abdominal transplant social workers could help with that, and kind of get that submitted and be able to advocate for the patient so they don't lose that resource. And we could certainly connect you, to the right person. If the patient doesn't know who their transplant coordinator is, we could certainly get them directed appropriately.
All right. Thank you. Let's see. So here's a question that was asked about, does treating infections like COVID or hepatitis C post-transplant have an additional cost, or is that part of the estimated $442,000 cost?
Louis, I think you would know that better, right? With your research, I would think that, I don't know, is the 442 kind of an average?
Correct.
Okay.
Correct. And I do.
That Tom is on the line. Tom, is there anything that you want to add to the conversation from a financial perspective, coordination perspective?
I'm going to have to ask if Annette can unmute Tom.
Hello?
Yeah, we can hear you.
Oh, okay. And what was the question again? I'm sorry. About bundled payments?
So, so the question was in regards to patients, as far as if they're post-transplant are affected by COVID or hepatitis C, as far as the cost, the estimated cost for a transplant was that 442,000. Does that cost go up if they're being treated for these different infections, or is that 440, is that part of like almost like a bundled, I guess,
Oh,
option?
okay. Yeah, my assumption is that that would increase the cost to, to treat the hep C. And if there's other issues that need to be treated, I'd assume that would, make it go up a little bit. Yeah, I think that is it 442 500,000. I think that's basically like an average, I would think, for transplants around the country, the United States.
But Tom, it makes sense to me too, even though it would increase the actual cost of their care. It is part of their care, right? So
Right,
we shouldn't have, it should be covered, right? Like from a payer perspective,
right.
right?
Yeah, the Hep C now, I think pretty much everyone's covering the meds now and the treatments. I haven't really heard of any denials anymore. So yeah, I think that's pretty well covered by insurance now. So
And Tom, I see a comment. I'm not taking your job, Jen. I'm sorry.
Nope. You're good. You're good.
I see a comment about a suggestion for a patient who's considering transplant but is afraid of the cost, right? Like my initial thought would be we need to get the facts. Like, don't spend your time being afraid of something we don't know the facts about yet. How would you answer that and elaborate on, right? Like, how would you help a patient through assessing that?
yeah, that's part of the reason we call every patient, and go over their benefits. Like they say, a kidney transplant's $442,000, but as a kidney transplant patient, you're never going to be billed $442,000. You're going to be, you have what your insurance out-of-pocket responsibility is. Um, and that of course renews every year, depending on what your coverage is. You'll see out-of-pockets range anywhere from, a couple $1,000s up to, $9,000, $10,000, depending on the policy. And sometimes prescriptions are included with the medical out-of-pockets. It goes by policy. So that's one of the big reasons we speak to everybody about their insurance benefits when they get referred for transplant.
And how do we work through those out of pocket when a patient is in a position where they can't afford it?
Oh, that's a big reason why we try and utilize like the SRS Medicaid program. Like if somebody comes in with just Medicare, and we try and utilize that because would sit secondary to actually Medicare or a commercial policy, and it would basically pick up the medical out of pockets because they would bill their primary first, then it would get sent to the Medicaid portion, and it would help pick up and meet that out of pocket cost. Or if someone has like a kidney patient, most eventually are eligible for Medicare, and hopefully they have another policy that'll sit secondary when Medicare becomes primary. And again, it's a secondary coverage that'll help pick up out-of-pocket cost. And then some folks can get some relief from, say, like University Hospitals has financial counseling department, and there is some financial assistance depending on your income. You could set up payment plans with the financial counseling folks. So there is some avenues to try and get some relief on out of pocket.
And I think we do right at the beginning of each year. In fact, we're already talking about, expecting this. We kind of get inundated, for lack of a better term, right, with patients, when they get assistance programs, right, for medications, for example, right. A lot of them renew at the beginning of the year, so they're required to have updated paperwork at the beginning of every year. So I know that the coordinators and the social workers, we work really hard, to help the patients to get that paperwork renewed. And it seems like it comes all at one time, right? January,
Right.
February,
Right.
is when those come. But
Right. Yeah, because those are all year to year programs.
Well, we're getting close to the end of the presentation. There was one question I do want to address, and that was asking what programs does the Kidney Foundation of Ohio do for transplant patients? If you can mute, yeah. What I will tell you is that with the Kidney Foundation of Ohio, our medication assistance, transportation assistance, emergency programs, those are our programs that patients can apply for through their social workers. Obviously, if a patient is 5 years out post-transplant, they're really no longer going to qualify for transportation because they're not going to 2 or more appointments for their kidney disease. They can still apply for medication. And then if need be, if the patient is struggling with rejection or having to go, having some complications, and they're further out post-transplant, we're able to provide some assistance. So the programs that we offer here at the Kidney Foundation are for transplant patients as well as our dialysis patients. So that is definitely something that we do provide.